Good evening, everyone present here. I am Faraz from IGCP Group. Welcome all the participants on today's live discussion and very important webinar on a very important topic, that is approach to unknown fever. As we know that fever is a very common scenario, and to understand how to approach and manage unknown fever. As we know that this topic is very important, so we need someone who is expert. So, without any further delay, I would like to invite our speaker with great honor, none other than Dr. T.N. Ravi Shankar, sir. And let me share some of the achievement of sir. Sir has done MBBS, DFM from Colombo, and FCGP and PGDMLE, and he MBA in family physician, and he is practicing as Sudar Hospital, Chennai. So, without any further delay, I would like to invite sir and hand over this webinar to sir. The stage is yours, sir. Over to you, sir.
Thank you. Thank you very much, IGCP, for giving an opportunity on this afternoon to talk on a very relevant topic in the present day scenario of the seasonal fevers and all these things. It's the most difficult one. It's a bread and butter of the family physicians and also the sword on the neck for a physician or an intensive care people. Fever, the most common problem when everyone will think that's most easy to manage, but the most difficult to come to a conclusion. Easy to manage the fever, but it's tough to find out the cause on a number of occasions. Quite often, we always say, just treat the symptom, it'll automatically get resolved. That's a one which is a common fever, but an uncommon fever is one which gives us a headache for the physician who's treating it. But let us go into the proper way of trying to find out what is the cause, evaluation, and how we go about it. What is fever? It's an immune response of the body. The hypothalamus raises the body temperature to make it unfavorable for the pathogens to survive. And that's the first response of the human system. And when the temperature is above 37 degrees centigrade, it is about normal. And when it goes above 38, it is generally defined as fever. Something between 38, 37 to 38. There are reactions that can happen in a human system. When you walk around, when you go in the sun, when you go in the cold, systems change according to the environment. And that change in temperature need not be taken as a fever. But if it prolongs, then I think we will have to classify where we stand. Intermittent fever, the temperature rises but returns to normal each day. At some point of time, there is a rise in temperature. At a different point, it comes back to normal. Remittent fever are temperatures that fluctuates daily but never returns to normal, like in an infantile endocarditis. You have the fever above the baseline always, and continuous sustained fever remains elevated with minimal variations of less than 1 degree centigrade, as in typhoid, never reaches the baseline. That is the hectic fever. Wide sinks in temperature, often with chills and sweats. If you have tuberculosis or abscess and relapsing fever, at some point of the day, you have a raise, you have a fluctuation, and all these things. People will be thinking why we always have a graph in a hospital whenever you have a fever patient, or in fact, for every patient who's admitted in a hospital. The graphs helps us also to come to a diagnosis. And classification is also based on the duration of the fever. If the fever is acute, which is say always less than 7 days, and if there is more than 3 weeks of no diagnosis, or your diagnosis have been misled, or have not come, the fever has not come into control, it is called as pyrexia of unknown origin. In between, you have a subacute and a chronic phase. When you have fever of 14 days duration, we sometimes land up with patients like tuberculosis or an autoimmune disease or malignancy. The whole topic, when you say uncommon fevers, land up in the chronic stage. It may be an autoimmune disease or a malignancy, and how to approach these fevers, let us see over the course of this half an hour. Classification can also be based on the etiology. It could be infectious, that bacterial, viral, parasitic, or fungal, and non-infectious or inflammatory, which is autoimmune malignancy, can be another cause like lymphoma, leukemias, and solid tumors. And occasionally it could be due to drug fever or an endocrine cause, which is miscellaneous. Except the first one of infection, the other three are uncommon fevers that can present for any practitioners. Once again, the same thing. And here, the one extra that has been given is the heat related illness. In a tropical country like India, summer season can always cause exhaustion, dehydration, and heat stroke can raise the body temperature dangerously. And non-infectious causes is the one which is the most common cause of an uncommon fever in practice. The autoimmune disease, rheumatoid arthritis, or a lupus, or an SLE, a patient can present with you with fever with no localizing signs. The inflammatory condition could be generalized, like in an irritable bowel syndrome, or it could be a drug induced or a heat stroke or a malignancy, endocrine, which we have seen the first slide, which I think I showed about the cardiac cause, endocarditis, but even a myocardial infarction, if not diagnosed, will be perplexed. But when you take an ECG, you might have a Q wave or an ST elevation. The necrosis of the cardiac tissue also can cause a fever. It is because the same way it can be a deep vein thrombosis or a pulmonary embolism can result in fever. Quite rarely, a cerebral hemorrhage and seizure can cause the gastric symptoms like ischemic colitis, pancreatitis, which is quite common in a country where alcohol is misused. That can also cause a fever. Those are the causes for a non-infective cause of fever, and then fever with comorbids, which we have to know. I think everybody will be aware of hypertension, diabetes in our country. Diabetes, we are said to be the capital in the world. And chronic respiratory diseases like COPD and asthma, that too after the COVID in our country, where people have been infected with COVID and subsequently have a restrictive lung disease. Chronic kidney disease, which predisposes to urinary tract infection and sepsis, can also be the cause of an uncommon fever that we need to look out, always have it in our mind before we come to a diagnosis. SLE, rheumatoid, cancer, aspiration, bedsore, and UTI. Fever in the ICU is mostly related to the infection that can happen in an intensive care, catheter related, ventilator associated pneumonia. Sinusitis is somebody who's on prolonged intubation or on a nasogastric tube. Urinary tract infection related to the Foley's catheter. Somebody lying down too often in the bed can result in soft tissue infection, that is pressure sores, cellulitis, abdominal infection, peritonitis, biliary infection, where there is going to be a stasis, colitis, and sepsis from any source can be there in an ICU fever. Non-infective causes are once again the same one, but let us go to some of the symptoms so that we are somewhere near the diagnosis clinically before we step into a diagnostic criteria. Chills with rigor, quite common, are with bacteremia, malaria, and sepsis. Malaria, I think everybody will be knowing, an alternate days fever or or on a particular time of the day when malarial parasitic activity is there. Night sweats are more common with tuberculosis. Somebody who have a slight raise in temperature by evening 6, 7 o'clock, or even at 5 o'clock, and then there will be a raise which slowly comes down to the normal baseline. And then you find that the person is active during the day and go back again to the fever phase by evening 4, 6, 5, 6 o'clock. And if you don't treat them appropriately, these fever gets started even earlier by 1 o'clock, 2 o'clock, and that is how we could come into a diagnosis of tuberculosis, lymphoma, or an endocarditis. Weight loss and anorexia for uncommon fevers are very, very common because the fever is not diagnosis. The anorexia goes on and you tend to lose the weight. And most common, we find the patient suffering from tuberculosis, malignancy, or HIV in a present day scenario. Cough with symptom, bringing down lots of phlegm, greenish or occasionally brownish. Common causes could be pneumonia or bronchitis. Cough with sputum can always be related to the patient's head setting down. Fever started with a mild headache, nasal block, and then finally, after 2 3 days, with no proper antibiotics or medication targeting the infection, can result in cough with extensive sputum. Dry cough persistent even after 5 days, 7 days, which we commonly see during the monsoon, are related to the viral fever or atypical pneumonias. That is very, very common in the present day. I think right now is a phase where we are finding it slowly coming down. Cough, fever, chest pain on a specific place, and that pain is increasing with cough. Could be due to the empyema or a pulmonary embolism when there is an acute dyspnea that can happen. Bleeding, gums, or when the patient complains of bleed when you are brushing or anything like that, could be any of the hematological disorders, but quite common in the present day scenario is dengue and a leptospirosis could always be a cause. Splenomegaly, when you find a clinical examination, you find a spleen palpable. It could be malaria, typhoid, based on the soft spleen and the hard spleen. We can always distinguish between malaria and a typhoid, where in typhoid we have a soft spleen and a firm spleen is quite common in a malaria, Kala Azar, and most of the hematological disorders. Headache, photophobia, neck stiffness, vomiting are associated with meningitis or encephalitis. Some child brought in with headache, fever, and vomiting should always suspect a viral meningitis in the present day scenario. Somebody with an altered sensorium and seizure can be a cerebral malaria, viral encephalitis, or a sepsis. Abdominal pain and diarrhea associated with fever can be an enteritis or an enteric fever, and somebody who misuses alcohol can have an amoebic liver abscess. When you have jaundice associated with fever, whether it is high grade fever or low grade fever, we need to think about a common cause in our country where they use water wherever they get it in the lower socioeconomic. It could be viral hepatitis or sometimes leptospirosis. Malaria, untreated, can go in for a liver disorder, altered liver function, and can have jaundice. A maculopapular rash, quite common with measles or in a drug reaction. Vesicular rash, which is a hallmark of pox or herpes zoster. You have a herpes zoster on a single neuritic phase with fever, low grade fever is also there. Arthralgia, severe joint pains, unable to walk, unable to get from bed, which we have seen it for quite some time. And in the last 1 year, I think we are seeing more cases of chikungunya. Influenza can present like this. Typical back pain with some urinary symptoms or pain in some of the joint spaces can be either osteomyelitis or pyelonephritis. Two conditions where you need to investigate thoroughly in depth to find out what is the cause of the fever. If you have a travel history, we can always relate it to the water contamination that could have happened, and that could be malaria, typhoid, or a viral hemorrhagic fever. People who have pets in their home, their dog, the cat, and all these things can cause brucellosis, leptospirosis, and rabies. Cattle, when they have cattle at home, somebody who are working in the farm, then you need to suspect brucellosis. The same is applicable when you have fever with a bit of respiratory symptoms. You try to search out for a ishar in the hidden parts of the body. There are people who had ishar in the genital region, in the breast, in the lips, are also been reported, and we need to suspect it could be scrub typhus. One I always find it when fever with chills. These are the conditions that we can always have an urinary tract infection. And adenitis, look out for in the axilla or in the inguinal region. Malaria, you can find out a firm spleen. And you have a soft right hypochondrium tenderness, intercostal margin tenderness. Somebody who have a cough and bringing out anchovy sauce pus. It could be amoebic liver abscess ruptured into the lung and coughing out. Abscess anywhere in the human system. And the last one we don't see quite common nowadays is the filarial adenitis. You take a blood sample in the night and see the worm wriggling under your microscope. You'll be thrilled to find out the diagnosis and put down an appropriate antibiotic with your diethyl carbamazine. I think the fever subsides, but then you need to have the patient treated for a long term to prevent any relapse. Physical examination is the one which is going to help you find out what is the type of fever and what could be the cause of the fever. The temperature, I think we have already seen the continuous, intermittent, remittent, and step ladder pattern, which we see, and that is why the graph which we have in the hospital will be very useful. And if you are in the outpatient treatment, please ask the patient to buy a thermometer and keep asking them to recording at least 3-4 times a day before taking their paracetamol or antibiotics and an hour or two after taking the paracetamol. Pulse, relative bradycardia in typhoid and in dengue, in relation to the temperature spikes, the bradycardia will be there, but nowadays not quite commonly seen or noted down. Blood pressure to see if the patient has got a sepsis shock, and if there is going to be dengue and then hemorrhagic fever, the pressure could drop down so badly that the pulse pressure will be too small and the systolic will be much lower than 100. Respiratory rate, very useful to find out and the patient has got a respiratory pneumonia or an sepsis. General appearance of toxic look in fever of long duration, pallor, icterus, and cyanosis are typical of the liver and the respiratory tract. And if the patient is dehydrated, like in a summer stroke, the tongue dry, the skin turgor is gone, then we can easily identify the patient has gone in for heat stroke and all these things. Lymphadenitis in the inguinal, posterior cervical, axillary, and supraclavicular can easily be identified, and if you miss it, you are bound to miss a lot. A supraclavicular node is very, very ideal if you are trying to find out anything in the GI tract, or sometimes even when you are trying to palpate there, you might land up with some node around the thyroid, which can give you a clue that the problem is in the thyroid. Skin and mucous membrane, a rash, as in measles, an eschar in scrub typhus, petechial rash in dengue and meningococcal infection, and herpetic vesicles, urticaria, and drug rash. Drug rash, you can note the patient giving the history that they get this rash with fever whenever they take those certain tablets. Cellulitis of the limb is always missed because the patient with fever with rigor will come closed with all the blankets and closed dressings. We miss finding examining the lower limb, but if you lift the dress or the blankets that they are wearing, we will always find that cellulitis or lymphangitis or either of the limbs, which can easily give you a mark for the diagnosis. Quite often, uncommon fevers, we always miss a common cause like cellulitis in the lower limb. Organ specific examination, the head and neck involve the pharyngeal congestion. A tonsillar exudates, if you examine the oral cavity, sometimes we have streptococcal pharyngitis or even a follicular tonsillitis could be easily be diagnosed. A neck stiffness, if you don't examine the neck, I think you make the patient lie down and try to move the necks on either side, you can always find out the neck stiffness. And the cardiovascular murmurs, the S3 murmur or a gallop, which are signs of myocarditis, the tachycardia out of proportion, the respiratory tract, you auscultate in all the both the sides of both hemithorax in all the stages, then you will be able to find out the crackles at specific places. Or if you have bronchi the entire both sides, or you have crepitations on both the lung field or in a specific place, then you can identify that area has got a pneumonic patch, or it could be an asthmatic bronchitis with an extensive exudate there causing fever for the infection. A pleural rub, which is very classical with the respiratory movement. And these are things clinically today not being often employed by the physicians or the younger generations who depend more on diagnostic tool. And if you clinch any of this and your evidence of scientific evidence gives it, then it will be easy to diagnose, come to a diagnosis even before your diagnostic tools are ready. Abdomen, I think I've already told you about the liver and spleen. And if there is tenderness at any specific place, then you can find that organ to that place. A liver abscess or even an appendicitis can also be found out. Seizure, sensorium, focal deficit is already we have seen. And a common evaluation in a fever we do is the first stage is to do a complete blood count. Look out for leukocytosis or leukopenia or a thrombocytopenia. When there is increase in the blood count, more likely to be a bacterial infection associated with the cause. And if there is a low count, it is going to be a viral dengue or something like that. And if you look out for the platelets, you will be aware that there is going to be a dengue or something which relates to malaria also. Malaria is a one which also causes a fluctuation in the count depending on the secondary infection that can happen in a comorbid patients where the dehydration can push the patient for a little bit of urinary tract infection. Very, very important test that which we always don't employ quite often is a peripheral smear, not only for picking up the malaria but also correlating with the complete blood count. That's very, very important in an endemic area. Urine routine and culture, as a routine, is necessary in a tropical country like us. Either the patient doesn't take the fluid properly or adequately, which can result in a urinary tract infection. ESR and CRP, the one which indicates there is an inflammatory or infection going on. Between the two, I don't think there is much difference, but CRP is quite often seen in an autoimmune disorder, giving us a lot of clue about the activity of the inflammation that can go on. Blood culture, very much needed before starting the antibiotic in a hospital practice, but in a private practice, it is not possible. But then when you find the patient coming to you with fever, non-resolving with your regular antipyretics, or the fever spikes keep going higher and higher, I think it is very necessary to take a blood culture, but it needs to be taken in a very appropriate way. 5 ml of blood, three different places, sent appropriately at the earliest to the laboratory, or the blood sample will have to be taken in the laboratory so that we don't miss anything by your technique of taking the blood. Basic metabolic panel like the liver function and renal function test is very important in fever, and that too in a liver function test in all the viral fevers. Even in the third day, fourth day, you can always have a raise in the liver enzymes. The raise in the liver enzymes can give us the clue whether it is a viral fever or a viral hepatitis, or an altered liver function because of your leptospirosis or because of your malarial fever. Chest X-ray necessary, absolutely indicated if there is a respiratory symptoms of cough, pleuritic pain, or pain that cough increases the chest pain because of cough. Ultrasound can pick up your hepatosplenomegaly, and also if there are mesenteric nodes or if there are peritoneal nodes. Sometimes you have in the woman causes a revolving around the reproductive organs, which can also be picked up well by an ultrasound abdomen. Specific tests are there for the dengue, IgM, NS1, done within the third day to fifth day, and that remains positive. IgM remains positive for another 2 weeks or even for 2 months. Typhoid, don't do a Vidal test to come to a diagnosis. Vidal test has become obsolete. It is only a relative test done in an interval to interpret it. You need to have a typhoid test or a blood culture taken to prove it is a typhoid. The best will be a stool culture. Scrub typhus, IgM ELISA, the same is applicable for leptospira. And today, everybody knows about COVID. You do have the test for COVID 19. Influenza, there is a huge panel of tests that can be done to diagnose which, but before you get the reports, most of the time patients come out of the symptoms and they thank you for having given them the relief. Throat swab or a rapid streptococcal test in sore throat, liver ultrasound, we have seen it. The next common test that does done CRP and serum ferritin for as an inflammatory markers. Viral panel, that is what I said, the fire panel. Peripheral smears, we have already seen about that. Lymphomas and anemias can also be picked up well by a peripheral smear test. A practical clinical approach, day 1 to 3 of fever, symptomatic management with a baseline investigation of CBC, urine, malaria, and blood culture if needed. If fever persists beyond 3 days or if there is a red flag appearance, add a target test for dengue, typhoid, scrub, and chest x-ray. If still diagnosed after 7 days, escalate to pyrexia of unknown origin and work up with a CT scan, advanced serology, and all the autoimmune markers. What are the markers? You need your CRP, ANA, anti-CCP, and RA factors. And when there is going to be a connective disorder, you need to take a proper history from the family. Quite often, more than 50% of the time, we can get back a family history or a history precedence that a recurrent joint pain that comes, gets settles with fever, maybe a skin lesion is there, fever of short durations, recurrent in the last 1 to 2 years, or a family history can always take you to the point of a connective tissue disorder. This is where an uncommon fever is. And there are times when the patient might have used a steroid in addition to the paracetamols to get relief. The steroid would have given relief for quite a long time, and then the relapse would have happened. Today, there is another argumentarium of a great investigation that is available. Of course, the cost involved is quite high, but when the patient has been on fever for a week or 10 days, they will not mind doing the PET scan, which can localize an occult infection, which can localize the inflammation or autoimmune disorder that is going on, and also help you to diagnose an undetected malignancy like your lymphoma, leukemias, or a solid tumor that can present with fever and a constitutional symptoms. Never hesitate do a PET scan for a fever of unknown origin. It can always help you to localize. If your blood counts are abnormal, but still you are not able to locate it with a specific ELISA test, you have no other choice but to do a PET scan to find out an occult infection. It can detect a deep-seated abscess, what I told you about a joint pain and osteomyelitis, endocarditis, or infected prosthetic valve that can be picked up by a PET scan. All the inflammatory disorders can also be diagnosed with a PET scan, which is very, very useful. But then please employ it judicially at the appropriate time, not misusing it because it is available for you nearby. And what are the danger signs in fever? If there is going to be a hypotension, your pulse pressure is too low, and your systolic BP is below 90, then it's a bad sign. Non-altered sensorium could be a meningitis, a bleeding disorder, can be your dengue or a meningococcal infection, jaundice and respiratory distress. can be leading to a multi-organ failure in your infection or a sepsis. These are the five signs that need to be looked out. The patient will have to be in a hospital or in an ICU center set up to manage the same. I think we have seen all these continuous fever, intermittent step ladder fever, and all these things. And another today scenario of a lot of home care patients who are there at home, who are taken care by caretakers or allied paramedical people. At that point, we need to think on all these things. A thromboembolic disease, a deep vein thrombosis, or a pulmonary embolism, fever with pain in the limbs, or an acute dyspnea, thromboembolic, environmental cause, a room without proper ventilation, then it could be heat stroke or hyperpyrexia. Sometimes there may be a limited monitoring. They might be feeding the person on the rice tube, not looking about the bowel movements and all these things. Limited monitoring, they would not have done it unless it had got an hyperpyrexia stage. Then we need to check out when, what, the pulse rate, and all these things. A polypharmacy or a drug interaction, bed sore, urinary tract infection, and pneumonia are common in a bedridden patients. Kindly take care in a home care patients for all these reasons. And treatment for pyrexia, your paracetamols. NSAIDs if there is no contraindications like CKD or an allergic reaction. Tramadol is another safe drug that can also help in reducing the temperature, and steroids when there is an autoimmune disorders. And more important on fluid management. If you don't provide adequate fluid, whatever fluid that is there in the extracellular compartment is going to be washed off, or it's going to be evaporated, that the patient will never get a relief from the hyperpyrexia. So please see to that the above are being done, and more important on the fluid management. The only condition where fluid management will need to be restricted is in a left ventricular failure patient with poor EF, or in a CKD patient who are on hemodialysis, or every other situation. I think we need to provide adequate fluid for the person. Specific antibiotics, anti-inflammatory, persistent fever, please re-evaluate, revise your diagnosis, and change your management accordingly. And don't hesitate to ask a second opinion from your seniors or from the peer group. And today, AA is there. That AA can always give you a differential diagnosis and can always provide you a path to take forward to come to a proper diagnosis. And thank you all for your time given on this festival day to listen to the topic, an important topic of fever and management. Thank you very much.
Thank you so much, sir, for taking out your important time and sharing your knowledge on this topic, sir. I definitely think this session knowledge is going to help all the participants on their practice too. Sir, we have received some questions, sir. With all your permission, shall we take these questions one by one?
Yes, yes, please, please, please.
First question is, sir, have you ruled out drug fever by reviewing all the current medication? And what if patient is stable, initiating a temporary drug holiday, sir? Can you please share some point on that?
Sir, if you find sir is going to be a drug reaction, I think stop all the drugs. Other 6 to 12 hours, the patient is going to be afebrile. See, your blood count is also going to be normal. The CRP, ESR may not go high, and there is no specific test that is going to be positive. Maybe your Vidal, if you do your Vidal, it's going to be confusion for you. If you do a IgG for any of these, finding to be positive, it's going to mislead you. A drug fever is one when you suspect that the patient has got a drug fever, stop the drug and see it for the next 12 to 24 hours. All you need is to explain to the patient that we are going to stop their paracetamol, that they are going to stop their NSAIDs, and then wait and watch and trying to find out. That's trying to find the cause of the, trying to locate that it is a drug fever. I think you need to stop the drug and try an empirical management. Put them on fluids, then it is all a reassurance to them that you stop the drug and find out that the cause is the drug fever.
Thank you so much, sir, for sharing your expertise to that question, sir. Moving forward, we have another question, sir. Are there any septal potential diagnostic clues, that is PTCs, on the repeat physical examination, or such a new heart murmurs or fundoscopic changes or temporal artery tenderness. Sir, can you please share some insight on that?
Yeah, temporal arteritis, again, vasculitis, autoimmune disorder. You don't have a murmur, or you have an old age person with a systolic murmur, and suddenly, that is what I said, a gallop coming around. S3, trying to pick up an X3, S3. Very difficult today in the scenario that we don't concentrate, but then today you have a good level of stethoscopes. You have an electronic stethoscopes also, which can always transmit the sound to your mobile and to see it. When you pick up a change in murmur, it's going to be an endocarditis. There is going to be a gallop, there is going to be a myocarditis. Today, the myocarditis should be not thought about that easily. People don't think about it that easily, for the reason today with viral fever quite common untreated on an immune compromise, they can land up with myocarditis. Number of times we have seen in the season viral fever pushing the patient to myocarditis, and always keep auscultating all over the chest, particularly on the cardiac place, to rule out any change in the murmur on a pre-existing murmur patient.
Thank you so much, sir, for sharing your expertise too on that question, sir. As I can't see any further questions, sir, I hope, sir, you have done justice to this topic and able to solve all the queries of the participants, sir. As there is no more questions, sir, with all your permission, shall we conclude this webinar for today?
Thank you for the opportunity to IJCP and MedTalks. Thank you very much.
Welcome, sir, and we would like to see you in future also in with different topics, sir. It was great honor to host you, sir. Take care.
Thank you very much. Thank you. Thank you.
Welcome, sir.